Thank you, Dr. Payne. It's my pleasure to introduce the next speaker, Dr. Brandon Coutu, who is a senior resident here, radiation oncology, or radiation oncology. So his topic is adjusting prostate nodal fields in response to positron emission tomography, computed tomography, PET-CT imaging. Thank you.
Oh, thank you, Dr. Zen. I feel bad for Dr. Rank because I think we forgot to tell him that we were all going to talk about imaging and management of prostate cancer. And so my talk isn't going away from that. In fact, I think that imaging and the intersection of imaging and management of cancer is a major pillar of research in our department. Of course, we do a lot of radiomics that Dan and Dr. Bain have really gone into depth with. Now I'm going to talk a little bit about the role of PET scans and how our recent use of flucyclovine PET scans has altered the way we manage biochemically recurrent prostate cancer. I don't have any disclosures. Some background information. We know that prostate cancer, especially high-risk prostate cancer, is a high risk of recurrence. And we detect recurrence by PSAs after either surgery or after definitive radiation therapy. To be able to effectively manage these biochemically recurrent prostate cancers, it's often critical to know where the cancer is at. And so advanced PET-CTs have really helped us come a long way in this endeavor. We use PET-CTs in prostate cancer to detect early detection of metastatic disease in the setting of biochemical recurrence after definitive therapy, also considering its usage in initial staging for high-risk prostate cancer. There's a lot of different targets that we've used for PET-CTs over the years. Our workhorse, of course, is FDG, fluorinated FDG, and we use this across many different cancer types. However, this hasn't been very effective and very specific for prostate cancer. Other molecules we've used, C11 choline has been made famous by Mayo. Other groups have used acetate. Today we'll talk mostly about flucyclovine molecules, and then we're excited about hopefully upcoming FDA approval for PSMA PET scans. When we consider a probe and its effectiveness for PET scan, there's a few different things we look at. First off, is it specific to prostate cancer? Is it going to prostate cancer and not going to normal prostate tissue or normal lymph nodes? And that really increases the specificity of a probe. Does the probe accumulate inside the prostate cancer, inside the cytosol, without being metabolically consumed? And so the more it accumulates in the cancer, the higher our sensitivity is. Then some practical aspects. Does it have a sufficient half-life so that we can get the molecule from the cyclotron and have it here for our imaging? And then one thing that's nice about flucyclovine and that we like for prostate cancer is it's not excreted in the urinary system. So it really helps us better assess the prostate bed or the intact prostate after radiation therapy. So I'll talk a little bit about flucyclovine. This is, so we are fluorinated an amino acid that is specifically brought into the prostate cancer through two different amino acid transporters, ASCT2 and LAT1. So we've recognized that these transporters are upregulated in prostate cancer. That's why this is a good and very specific way of identifying prostate cancer using an F18 probe. A few things that are nice is not metabolized or incorporated into new synthesized proteins in the prostate cancer, and it's not excreted via the urinary system, as I mentioned. So when we consider adopting a new probe for a PET scan, there's a few things that we consider. First, is it accurate? Are we able to accurately identify where the prostate cancer is using this probe? Second, is it practice changing? When we find when we do these scans, does it actually change how we are going to manage these patients? Or is it just something that we're doing because we like that self-assurance that we know that we're treating the right area? And then finally, does it affect outcomes? So this is going to kind of be how I organize the rest of my discussion today. I'll be presenting some early data that was used to seek FDA approval for flucycline PET CTs. And then I'll talk about some of our own data where we've assessed the degree to which these PET scans have changed our practice and changed how we manage these patients. And then kind of future directions, where we're going from here. So is it accurate? So this is a study that was used to seek early FDA approval for Axon PET CTs. They had three separate radiologists look at a series of scans, and they correlated this with pathologically confirmed findings. And so what we find is that there's a high rate of true positives of patients that were the flucycline, the AVID area correlated to pathologically confirmed sites of disease. And this was especially true in outside of the prostate, especially regional recurrences after radical prostatectomy. And that's kind of where we're going to be focusing on for this talk, is the knowing where these involved lymph nodes are and how that changes our management. So this reassured us that these PET scans are helpful in helping us identify where the prostate cancer is after radical prostatectomy. And so after that study was published, the FDA approved flucycline 518 PET CTs for prostate cancer in about 2016. The indication was patients that had undergone definitive management and then had a biochemical recurrence. So we started using Axon PET CTs at UNMC in early 2018. And from 2018 until the end of 2019, we had 225 patients that underwent an Axon PET CT to evaluate biochemical recurrence after definitive management. That could be a prostatectomy or could be definitive radiation therapy. In some cases, it was patients that had a prostatectomy, had already had salvage radiation therapy, and then were presented with biochemical recurrence after that treatment. And so we can see kind of a cyclical nature of when patients were getting their PET scans over that time, and then our increased patient population over time. And so what I want to address mainly with our study is it practice changing? Right now, there's limited data on the degree to which the results of the flucycline PET CT changed the clinical practice. We sought to investigate this in patients that had a PET CT after definitive management. Specifically, we wanted to know, is a flucycline PET CT worthwhile in the early salvage setting in patients that have a very low PSA after a prostatectomy, or with early indications that they have a biochemical recurrence after radiation therapy. There are some studies that suggested that the yield is very low in this subgroup. And then to what extent do PET CT findings affect our radiation fields and doses? Do we change our fields based off of these PET scans that we're ordering? Or are we changing our doses based off of them? These are expensive tests, and we want to make sure that it's impacting our patients in a positive way. And so we did this study with, this is with Dr. Ank and Dr. Bang, and we collaborated with radiology as well. So we analyzed those 225 patients. They were assessed both prostatectomy, radiation therapy, or prostatectomy and salvage radiation therapy. Of the 225 patients scanned at UNMC, only 121 of them were actually managed at UNMC. The other 104 were outside referrals that were here just for their imaging, and then went back to their outside hospital for the balance of their prostate cancer management. However, we included both of these groups because they will help us identify where these positive findings are. These patients had a variety of Gleason scores, a variety of stages, and nodal involvement at the time of diagnosis. We included 20% of them were going to have positive surgical margins after prostatectomy. The median PSA for the entire population was 1.42 at the time of the scan, and the PSA velocity was 0.77. So positive findings, we wanted to see what factors were correlated with the positive finding on the PET-CT, and that positive finding could be a lymph node that was avid, or positive findings within the PET scan, or within the prostate bed, distant osseous disease, or distant visceral disease, including in the liver or lungs, perhaps. On univariate analysis, age was associated with positive findings. So an advanced age, the median age for patients that had a positive finding was 72.5 versus 68, and that was significant. That was statistically significant on univariate analysis. Definitive therapy, patients that underwent definitive radiation therapy were more likely to have a positive finding compared to those that underwent a prostatectomy. And this may take a little bit further explanation in that we were concerned that some of these positive findings may actually not represent prostate cancer, but rather prostate tissue. Median PSA was identified on univariate analysis to be significant. There was a trend to PSA velocity that did not meet significance. On multivariate analysis, again, definitive therapy was associated with a positive scan, and median PSA at the time of the scan. So a higher PSA was associated with positive scan. So this is looking at patients that were getting imaging after a radical prostatectomy. None of these patients had radiation therapy. What we see here is that the positive rate significantly increases with increasing PSA values. But what's notable is even in patients that had very low PSA, less than 0.2, a fifth of them still had positive scans. And again, between 0.2 and 0.5, almost a quarter of them had positive scans. So this suggests that there is quite a utility in getting these scans, even in these low PSA values. We also see the increasing risk of pelvic lymph node and periaortic lymph node involvement with increasing PSAs. This is similar to those that are getting radiation therapy. Even in low PSAs after radiation therapy, 0 to 2, we saw a high rate of positivity that increased with increasing PSA. And similarly, pelvic and periaortic lymph node involvement increased with PSA. So I want to take a step back for a second and discuss how we typically do nodal coverage in patients that have biochemically recurrent prostate cancer. If you were to enroll a patient on RTOG protocol, they would want to see that your nodal fields are as such. They want coverage of the common iliac, internal iliac, and external iliac lymph nodes, presacral, obturator, and periprostatic lymph nodes. And this is done by adding a 7 millimeter CTV margin around iliac vessels, with the superior border being at the L5S1 junction and the inferior border at the top of the femoral head. And so this represents where the vessels are, and then in cyan is the radiation field specific to the nodal coverage. The common doses, and the most common doses we use here, are 4,500 centigrade and 25 fractions to the pelvic lymph nodes. And in the biochemically recurrent setting after radical prostatectomy, we do 6840 centigrade and 38 fractions to the postoperative bed. This figure is patients, is all of the involved lymph nodes of any of the 225 patients that had involved lymph nodes. We mark them in purple if they're outside of that standard radiation field, or orange if they're inside that standard radiation field. We identified a total of 72 positive lymph nodes on imaging, 29 of which were periaortic lymph nodes, and all of those periaortic lymph nodes were outside of the standard nodal coverage. Of the pelvic lymph nodes, we identified 43 pelvic lymph nodes, 13 of which were outside of the RTOG nodal coverage. That could be because they were inguinal lymph nodes, or they were lymph nodes that just weren't within that 7 millimeters of a CTV. We included, so you can see, for example, there's one that was just outside of that. There's one that's maybe an inguinal lymph node. A lot of these are kind of perirectal lymph nodes that aren't covered by the either the prostate bed field or the lymph node field. It's been interesting as we've kind of learned a lot about the pattern of failure for these patients by looking at these PET scans. Interesting phenomenon we often see is that this area between the psoas muscle and the vertebral body is a high risk area for recurrence. Even there's patients where this is even more posterior than this, this purple lymph node represented here. Oh, so how did these PET scans adjust our management? Of the 225 patients, as I mentioned before, 120 were managed at UNMC. 57 patients underwent radiation therapy after their PET scan. Of those 57 patients, 44% or 25 patients had either their volumes adjusted or their doses adjusted as a result of that PET scan. Looking specifically at the patients after radical prostatectomy, we had 72 patients managed at UNMC. Their median PSA was 0.45 with a PSA velocity of 0.29. 48 of them at the time of finishing this analysis, or 67%, had radiation therapy after their PET scan. The radiation fields were adjusted to include these positive lymph nodes in 23% of those patients. In 31% of patients, there was a simultaneous integrated boost to increase the dose to those positive lymph nodes. The median boost dose was 72 gray. Additionally, one patient underwent SBRT to a distant target that was identified on a PET CT. Similarly, 5 patients, or 25% of patients that underwent a radical prostatectomy and salvage external beam radiation therapy and then had biochemical recurrence, got a PET CT, underwent SBRT to a PET avid area. And so what we see here is that there was actually quite a significant adjustment in the management of these patients based off of those PET scan findings. There's a number of limitations with this study that need to be addressed. First of all, this is a single institutional retrospective study, and we were unable to assess the management in a large portion of patients that had PET scans as they were being managed outside hospital. This is an immature data set. We want to go back and finalize the evaluation of these patients, as many patients had not been worked up after their PET scan, had not completed their radiation therapy. Outcome data is not available. So although we're discussing how our radiation fields and doses were adjusted, at no point did we address how these impacted patient survivals. And that will, as this data matures, we'll be looking into that. Finally, this is a difficult analysis in that this is a very mixed and heterogeneous population of both patients that had surgery, definitive radiation therapy, and salvage radiation therapy. This complicates our ability to assess or to really stratify the benefits in each of these subgroups. Finally, the initial data to assess accuracy for PET CT, for actin PET CTs, they had pathologic confirmation as gold standard, and very few of these patients had biopsies after their PET scan. And so with these limitations in mind, we did make some conclusions off of this data set. That is that flucyclovine or actin PET CT is beneficial in the early salvage setting following radical prostatectomy, as 19 to 23% of patients we did find positive findings in them with a PSA of less than 0.5. Radiation doses and fields were adjusted based on that PET CT findings in 44% of patients undergoing salvage radiation therapy. And our standard RTOG contours failed to cover the entirety of at-risk nodal basins in these patients that are undergoing salvage radiation therapy. Future directions, I mentioned that third hurdle is how do we assess the efficacy, or as we change these radiation fields, how does this affect patient outcomes? And that's kind of our future direction with this data set. We wanted to complete post-PET CT management assessment, evaluate outcomes in these patients. As we've identified more PET positive findings in the prostate, we increase our interest in using salvage brachytherapy in these patients after external beam radiation. And then we're looking at the benefit of SBRT in the early or the oligometastatic setting, which has been kind of an interesting year for that, with the results of Oriole coming out and showing an overall survival benefit in prostate patients with oligometastatic disease that are getting SBRT. So, thank you. So I'll take questions.
Brandon. Thanks again for all speakers for excellent talk.